Continuing on our discussion of heart murmurs from the first lecture. In the first lecture, we discussed the systolic murmurs in great detail. Now let's continue from there, and in this part of the second part of this lecture on heart murmurs, we are going to discuss the diastolic murmurs in great detail. And along with it, in the latter part of the lecture, we are going to discuss some diagnostic modalities which are helpful in establishing a definitive diagnosis in the lieu of our clinical judgment and our auscultation findings. So let's continue our discussion of heart murmurs. All right. Now we are going to discuss in details what are the various diastolic heart murmurs. As you know, diastole is that part of the cardiac cycle in which the ventricles are relaxed and the blood is pooling up into the ventricles. It's the relaxing time of the heart and in which there is no output of the left ventricle. So the outgoing valves are closed and the mitral and the tricuspid valves are open. Here it's a schematic presentation of what is a diastole. It is that part of the cardiac cycle between the second and the first heart sound. The atrium are pulling the blood into the ventricles, and the mitral and the tricuspid valve are open, and the aortic and the pulmonic valves are closed. So, continuing the way we discussed the systolic murmurs, the part of the cardiac cycle gives us a good indication of what are going to be the valvular pathologies in this context. So let's look at a few types of diastolic murmurs. We're going to start with the early diastolic murmurs. These are the murmurs which start right after the second heart sound and then progressively decrease. They don't extend to the whole extent of the diastole. So, as you know that in diastole, the aortic valves are closed. So, whenever there is any problem in the closure of the aortic valve, that is any pathology because of the left ventricular dilatation or the aortic root dilatation, it can lead to the aortic regurgitation or the incompetence of the aortic valve. So in that case, we are going to hear an early diastolic murmur of aortic regurgitation, which, as I just told you, begins right after the second heart sound and continues and then progressively declines. It is a decrescendo murmur, a murmur which starts decrescending right from the start of it is at the maximum amplitude right after the second heart sound, and as we go in the diastole, it goes down. This is because the pressure gradient is greatest at the time of the second heart sound, when the aortic valve should be closed. At this time, there is the greatest pressure gradient between the ventricle and the aorta. So as progressively the diastole continues, the pressure gradient starts decreasing, and this leads to the decrescendo shape of this aortic regurgitation murmur. What are the various pathologies that can lead to aortic regurgitation? I just told you that any thing that enlarges the aortic root, that can lead to aortic regurgitation. For example, as we know that in patients with coarctation of aorta, there is some narrowing or obstruction on the aortic arch. So that leads to backward pulling of the blood, and it can lead to enlargement of the aortic root. And that will lead to a slight murmur of aortic regurgitation in some patients. Similarly, in patients with infective endocarditis, they can present with an aortic regurgitation murmur. What happens in aortic regurgitation is that during diastole, when there is supposed to be no transfer of blood between the ventricles, between the left ventricle and the aorta, the aortic valve is unable to completely close. And so there is some backward flow of blood from the aorta to the left ventricle. This leads to an increase in the diastolic volume of the left ventricle. Left ventricular end diastolic volume and the left ventricular end diastolic pressure both are greatly increased. And as there is increased volume of blood in the left ventricle, there is increased stretching of the left ventricle. And then in the next systole leads to a greater volume of blood being pumped out of the heart. So these all lead to the basic problems which are happening in the patient with aortic regurgitation. There will be a hyperkinetic circulation. The patient will have large bounding pulses. The pulse pressure will decrease because there will be an increase in the diastolic pressure, and the systolic pressure remains generally the same, but the diastolic pressure increases. So the pulse pressure decreases, and there is greater amount of blood being pumped out of the heart. There will be hyperkinetic or bounding pulses. The patient can have a rebounding of the head with the pulses, and there can be pulsations of the nail bed. So these are generally the pathologies which are happening in aortic regurgitation, and it is generally an early diastolic murmur. Similarly, following our pattern, pulmonary valve is also an outgoing valve. It is between the right ventricle and the pulmonary artery. And similar to the aortic regurgitation murmur, the pulmonic regurgitation murmur is also an early diastolic murmur, and it is more or less the same shape as the aortic regurgitation murmur, the decrescendo shape murmur, and it starts after the second component of the S2. As you know, the P2 is the second component of the S2 because it slightly closes later than the A2 because of the increased blood flow during inspiration to the pulmonic valve. So this is the similar picture as we discussed in aortic regurgitation. So both the outgoing valves are the ones which are affected in the early diastole, and they lead to the murmur of the early diastolic murmur of regurgitation murmurs, primarily of the aortic valve and the pulmonic valve. Similarly, pulmonic regurgitation can occur in some patient because of some problem with the pulmonary artery. If the pulmonary artery is hypertrophied or enlarged, then this can lead to the enlargement of the pulmonic valve ring, and it can lead to a murmur of pulmonic regurgitation. So generally it is because of some problem going on in the pulmonary artery, maybe because of the pulmonary hypertension, because of the left heart failure, or maybe because of the COPD in some patient. It can eventually, if that disease progresses, it can lead to a murmur of pulmonic regurgitation. It is very uncommon, but for the practical purposes, for the completion of the discussion, you should keep in mind that similar to the aortic regurgitation, the murmur of pulmonic regurgitation is also an early diastolic murmur. Now let's move on and discuss some murmurs which begin in the mid-diastole. They don't begin right after the S2. They begin after slightly when the diastole has started. Majorly they start in the middle or the late part of the cycle. They are practically termed as the mid-diastolic murmur. They also include some murmurs which are late diastolic. The most important murmur to discuss in this context is the murmur of mitral stenosis. In the early diastolic murmurs, just remember the outgoing valves, the aortic and the pulmonic valves. In the later diastolic murmurs or the mid-diastolic murmurs, you should remember the atrioventricular valves, the mitral valve and the tricuspid valve. And more importantly, the mitral valve. Mitral stenosis is the major thing which we are going to discuss in the middle to late diastolic murmurs. You know, the mitral stenosis presents with a mid or the late diastolic murmur, and it begins after an opening snap. Now, what is this opening snap? It is important to understand. What happens in diastole is that when the left atrium starts contracting and there is opening of the mitral valve, it leads to the blood going from the left atrium to the left ventricle during diastole and filling up of the left ventricle during the period of cardiac relaxation. Afterwards, when the diastole is over, the mitral valve flows. So during diastole, mitral valve is supposed to be open. So when the diastole starts, and the early part of the diastole, the atria begins to contract forcefully and the mitral valve starts opening. But because there is some pathology going on with the mitral valve in mitral stenosis, it is unable to be completely opened. So it starts. So rather than opening in a normal way, it just starts opening and halts its motion halfway or just in the beginning. This abrupt halt in the motion leaflet of the mitral valve, or the abrupt stoppage in the opening of the valve, is what gives rise to this opening snap. It is like a snap, a voice of a snap, that the mitral valve is opening and it starts immediately halts its motion or halts its movement. And afterwards, it leads to a rumbling or a late diastolic murmur which signifies that the patient has some mitral valve pathology going on. The murmur of mitral stenosis, it starts right after the beginning of the opening snap. And a very important point which we are going to discuss further in the coming slides is the intensity of the murmur can be predicted by the distance between the second heart sound S2 and the opening snap. It is in the distance between the second heart sound S2 and the OS, the S2 and OS distance is inversely proportional to the intensity of the murmur or the pathology of the disease. If there is a greater distance between the S2 and OS, this means that the disease is this means that the patient doesn't have a lot of very serious disease. It is inversely related, and in that case the murmur will be shorter. But if there is a smaller distance between the S2 and OS, that means that the severity of the disease is more and the murmur will be longer. So this is an important point to remember regarding the intensity of the mitral stenosis. Now let's look at the same concept in slight more detail. Here we are going to show you, here we are going to compare just one important point of between them if a patient has a milder disease of mitral stenosis or some severe pathology. Let's look at these pictures in context of an ECG. You know, when the ventricles are contracting here, the QRS complex is forming on the ECG. This is roughly the point where the first heart sound is produced. This is the whole period of ventricular contraction, or the systolic period. When the systole is over, the second heart sound S2 is produced, and now this starts the period of ventricular relaxation, or the diastolic period. And here this is the point where the ventricles are filling up with the blood. This is the whole diastolic process, in which we have a P wave as well, which signifies atrial contraction in the systolic process, in the diastolic process, I'm sorry. So if a patient has a milder disease as compared to a severe disease, what is going to be the difference on a piece of paper if you want to project it? Whenever the systole starts, let's start from here. Whenever the diastole starts, there are three parts of the diastole. The first is the immediate part right after when the valves have opened, the early diastolic period when the atria are contracting, and then it leads to a mid-diastolic period, and then a latter part, or the end diastolic period, in which there is some pre-systolic accentuation or decrease might go on. So in a patient with mild disease, the two important components which are going to be present are, number one, right when the diastolic period has started, there is a greater pressure gradient between the valve, the greater transvalvular pressure gradient between the atria and the ventricle. So the murmur of a patient with mild mitral stenosis is going to be evident in two major parts. Number one, in the early part of the diastole, right after the valves have opened, in the early diastolic part. And then there is going to be a pre-systolic. This is the systole, after the S1 it is starting. So there is going to be a pre-systolic accentuation of the murmur. There won't be any murmur present in the middle part. So this shows that the mitral disease is comparatively mild, as it is evident in two parts, two out of the three parts of the diastole, in the early diastolic period and then in the pre-systolic period, when we are going to hear the murmur in great detail. Similarly, you can see here, this is the pre-systolic part, which we term this as pre-systolic accentuation, or the pre-systolic increase of the murmur. And this is right after the opening snap in the early part of the diastole. Now let's compare this with the patient who has a severe disease. This might be a patient who had rheumatic fever, and then it started off with an early mitral stenosis or a milder disease, and it has progressed to that severe mitral stenosis if the patient remains undiagnosed or the disease remains uncorrected. In that patient, as you can see, if we compare these two pictures, the murmur of the mitral stenosis is present throughout the diastole. This shows that there is a progressive disease in all parts of the diastole, and the pathology is majorly severe as compared to a milder patient. So these two waveforms are the ones which we have to understand. If we have a picture waveform of a murmur like this means that the mitral stenosis is evident right after the opening of the mitral valve, and it goes throughout the diastolic period. So it is just a comparison of a milder disease with a severe disease. The murmur of mitral stenosis presents after the opening snap, as we just discussed, and eventually this can lead to the atrial dilatation. It can lead to the pulmonic hypertension, which can lead to pathology with the pulmonic valve as well. And you can see that progressively the P2 component can become increased or louder in these patients with severe disease of mitral stenosis. So this is just an explanation regarding the comparison of the milder or severe form of mitral stenosis. All right, this completes our discussion of the systolic and the diastolic murmurs. Now let's look at a few continuous murmurs. The continuous murmurs are the ones which are present throughout the systole and the diastole. The waveform of the murmur will be somewhat like that. The murmur will start right after the S1, and it is generally the loudest at S2, and it can obliterate S2 as well. It will be difficult to hear S2 in the presence of such a loud murmur, and then it progressively goes down during the diastolic. So this is the classic crescendo decrescendo murmur, a continuous murmur which is present throughout the cardiac cycle involving both the systole and the diastole. The major pathology you have to remember in context with the continuous murmur is a patent ductus arteriosus. This murmur of, as you know, ductus arteriosus is during the fetal period. Ductus arteriosus is a connection between the aortic arch and the pulmonary artery, because the lungs are not working in the fetal period. So this abnormal communication keeps the blood flow going. But right after when the baby is born and the baby takes his first breath, and the prostaglandin levels, which are keeping the this ductus arteriosus open during the fetal period, it starts going down. There will be a natural closure of the ductus arteriosus, and it is transformed into a ligament in the later on life. But in some patients, because of abnormally low oxygen tension, or there is not a decrease in the prostaglandins, or some pathology with the lungs going on, the murmur, the ductus arteriosus remains patent and does not close naturally. In those patients, we are going to appreciate this murmur of this continuous murmur of ductus arteriosus, patent ductus arteriosus, and it especially, you can hear this murmur in the left infraclavicular area, just below the clavicle. If you put your stethoscope, you're going to hear it like a machine murmur, like just a machine going on and it's working. So this is the major pathology which is relevant in the context of continuous murmurs. The continuous murmurs can also be a normal phenomena, or for example, if we have a patient in which we have an AV fistula going on, or there is some abnormal communication between the arteries and the veins, that can lead to a continuous murmur or a venous hum. AV fistula can be, we can make the AV fistula artificially in patients of dialysis as well, or there can be some AV malformations naturally occurring. So that is another thing to keep in mind. But the most important pathological thing to remember here are the patent ductus arteriosus in relation to the continuous murmur. Now let's discuss another thing, which are the to and fro murmurs, and then we are going to compare them with the continuous murmurs. Sometimes, as it happens in medicine, as you know, the things can be very complicated. So in a same person, in a same old person, we can have two pathologies going on at the same time. And it is not very uncommon. When you start to practice in medicine, especially, you're going to see a lot of patients with complicated diseases. So if we have a patient, an old patient, which has multiple pathologies going on, and it is very much possible that there are multiple valvular lesions going on at the same time. So if a patient has both the aortic regurgitation component, for example, which is evident here with the help of a crescendo-decrescendo murmur, and similarly the aortic valve is enlarged because of some dilatation of the aortic root. For example, a patient has a bicuspid aortic valve, and then with the later on age, that bicuspid aortic valve will lead to this murmur of aortic stenosis in the 50s or 60s, and then later on going afterwards, there is some dilatation of the aortic root because of hypertension, or enlargement of the left ventricle, or some any other pathology, effective endocarditis or anything else that leads to the dilatation of the aortic root. This can lead to concurrent aortic regurgitation and aortic stenosis in a patient. So in such patients, the presentation of the murmur can be a bit confusing, and we might hear a continuous murmur. But here it is very important to differentiate between the two. In the continuous murmur, there is an increase in the intensity of murmur during the systole, and then it later on decrescendos. But the murmur of the to and fro murmurs are differentiated because there is a gap between the two parts of the murmur. You can easily see that the murmur of the aortic stenosis starts as a crescendo-decrescendo, but it tapers down before the second murmur has begun. So there is no continuity in the both murmurs. This waveforms are just there to differentiate the two pathologies. That if you have an older patient who has both the problems going on, so how do we differentiate it from a continuous murmur? In a continuous murmur, the maximum point of the murmur or intensity of the murmur is around the second heart sound. While in the to and fro murmurs, the two distinct murmurs are different from each other, and there is some gap, which is when we are hearing the murmur with the help of a stethoscope, which you are going to appreciate, between the two different pathologies occurring concurrently. So this is an important waveform to just understand the difference between continuous murmurs and the to and fro murmurs. Now, this is an important part of the lecture, and I want you to concentrate here. There are certain bedside maneuvers which we can perform, which are going to give us a very good indication of the murmurs which we are dealing with. And they give us very important clinical clues. So these are important to understand and remember what is happening in relation to the different dynamic techniques or the different bedside maneuvers we can do with the patient before going on to the majorly expensive or the time-consuming investigations. And these will help us tailor our investigations to the point of where we want to concentrate, rather than doing all the random diagnostic procedures, diagnostic techniques, modalities, which are going to be cumbersome for the patient as well, financially, and as well as they are time-consuming. To start off, let's discuss respiration. Now, as you all know, that respiration, there are two components, the inspiration and the expiration. During inspiration, you know that the air starts moving into the lungs, and because of there is a decrease in the transthoracic pressure, the transthoracic pressure becomes negative. The lungs become a pooling organ. During the inspiration, they start pulling the blood towards it. So during inspiration, the blood from the right hand side of the heart goes to the lungs, and as you know, there is delayed closure of the pulmonic valve because of increased flow of blood from the right side. So all the right sided heart sounds, be the components of the heart sounds, for example, related to the tricuspid valve or the pulmonic valves, or the right-sided additional sounds from the murmurs, or the right-sided S3 and S4, they increase during the inspiration. Whenever we are going to hear a right heart sound concerning the right atrium, the right ventricular, or the valves involved, we concentrate on the patient and we ask the patient to inspire slowly, and we hear during the inspiration. So the take-home point is that all the right heart sounds increase during inspiration. Opposite to that, during expiration, all the left heart sounds that are the mitral valve sounds and the aortic valve sounds, they increase during the expiration, because during the expiration, when the air is moving out of the lungs, there is a decrease in the blood flow from the right side and increase in the blood flow to the left side. It's a similar concept as from the expiration. So for example, if we want to hear a murmur of aortic regurgitation or a murmur of aortic stenosis, we ask the patient to inspire normally and then hold its expiration for a couple of seconds, so that we can concentrate during expiration and hear the murmurs of the left heart sound. So this is an important differentiating point when you are concentrating. For example, if you are examining the mitral area and you suspect that this patient has mitral regurgitation, you ask the patient to have a normal breath, and when the patient starts expiring, ask him to hold his expiration for a couple of seconds and concentrate during this expiration, because the murmur will become louder as compared to the inspiration because of the increased blood flow during the expiration to the left heart. So this is an important point regarding the respiration. Now, let's look at some bedside techniques which we can employ to augment the blood flow to the heart, to augment the preload or the blood going to the heart, or the afterload, the blood or the pressure against which the heart has to contract. So I'm going to explain this with the help of a whiteboard and to make the things clear, and this will give you a greater understanding of what is going on here. Now there are two major components, preload and the afterload. If we do certain bedside maneuvers, for example, if you ask the person to do a hand grip like this and move pressure, exert pressure here, this will lead to the contraction of the peripheral arterioles, and this leads to an increase in the afterload or the total peripheral resistance in the body. Similar process can occur if you inflate the BP cuffs on the both hands, or you give the patient a vasoconstrictor like norepinephrine or any other drug. This leads to an increase in afterload. Now, what happens to certain murmurs in lieu of these bedside maneuvers? This will, whenever we ask the patient to perform this maneuver and we simultaneously auscultate the chest of the patient to listen to the murmurs. Now, if we ask the patient to do a hand grip, this will lead to an increase in the afterload. You know, afterload is the pressure against which the heart has to contract. So in all these terms, I just want you to concentrate on three types or three murmurs, and this will give you a very good understanding of what is going on. The first murmur we are going to concentrate is the murmur of the hypertrophic obstructive cardiomyopathy. It is a systolic murmur, a crescendo decrescendo murmur. The other murmur is aortic stenosis, and the third one is mitral valve prolapse, and then rest of the murmurs. We are going to change the various modalities in relation to the preload and the afterload, and then we are going to discuss what is going on. So, for example, if a patient has an increased afterload, in hypertrophic obstructive cardiomyopathy, there is the septal thickness and the left ventricular thickness, and there is greater pressure in the left ventricle. So any maneuver that leads to an increase in the afterload will be going to exert a pressure down the stream, and this will lead to opening of the obstruction which is created in the outflow tract in the hypertrophic cardiomyopathy. So this leads to a decrease in the intensity of the pathology or a decrease in the pressure, and this will cause a decrease in the murmur of the hypertrophic obstructive cardiomyopathy. So the murmur of hypertrophic obstructive cardiomyopathy decreases with the increasing afterload. Similar concept is involved in aortic stenosis. There is an outflow tract obstruction through the aortic valve, and there is a greater pressure in the left ventricle and compared to the aorta. So when the aortic pressure increases because of the increase in peripheral resistance, the valvular pressure starts decreasing and the murmur of the aortic stenosis also goes down. Similarly, just remember this, whatever happens with hypertrophic obstructive cardiomyopathy, the mitral valve prolapse the murmur of the mitral valve prolapse goes the same way. This is just easy to remember. And so with the increase in the afterload, the murmur of the mitral valve prolapse goes down. There is a decrease in the intensity of the murmur, and the decreased intensity means that there is as you remember, that in mitral valve prolapse there is a mid-systolic click followed by a murmur. So when we say that the intensity of the murmur goes down, it means that the mid-systolic click moves towards the S2 and the duration of the murmur goes down. So these are the murmurs which are going to go down with an increase in the afterload. The rest of all the murmurs, they are going to increase. For example, the murmur of the mitral regurgitation, there will be an increased regurgitation of the blood flow to the mitral valve. This is what happens with an increase in afterload. Now let's discuss a few things which happen when we alter the preload. Again, we are going to discuss these in lieu of these three murmurs majorly, and then the rest of the murmurs, the hypertrophic obstructive cardiomyopathy, mitral valve prolapse, and the aortic stenosis murmur. Now, if we increase the preload in a patient, how can we increase the preload? For example, if we give the patient a V-node constrictor, the preload is going to increase, and it's going to increase the blood flow to the right side of the heart. Or if we ask the patient lying down on the bed to raise his or her leg, this will lead to a greater blood flow to the heart. This can increase the preload. Or if we ask the patient to squat, whenever we squat, we constrict our peripheral vessels, peripheral venules, and the blood starts going down to the heart. So these are the various bedside maneuvers we can do to increase the preload. Again, concentrating on the hypertrophic cardiomyopathy murmur, what happens with preload is that there is greater blood flow through the heart. So this increased blood flow lead to an decrease in the pressure or the obstruction. There is greater blood flow, so there is the heart becomes a bit larger as compared to a normal process. And in this enlargement of the heart leads to will relieve the obstruction and lead to the increased blood flow through the obstructing part of the patient with hypertrophic cardiomyopathy. So similar concept, the murmur of the hypertrophic cardiomyopathy goes down in patients with an increase in the preload. And I just told you that you have to follow the same pattern for mitral valve prolapse. Similarly, in a patient with mitral valve prolapse, the murmur intensity goes down, the murmur will become shorter, and will move the mid-systolic click will move towards the S2. Aortic stenosis is a different thing in this bed, because when the preload is increasing, there is increasing pressure in the left ventricular part. So this adds to the increased transvalvular gradient. So instead of the murmur So the transvalvular pressure through the aortic wall will increase. The left ventricular pressure will increase further as compared to the aortic pressure, and this will lead to the increased intensity of the aortic stenosis murmur. This is an important point to understand, and it is different when we were discussing the afterload. When the afterload was increasing, these murmurs were going in the same direction. But in this part, this is an important difference from the afterload pathology. The rest of the murmurs are altered according to their movement. For example, the murmur of the mitral regurgitation, generally the murmurs go increase. For example, the murmur of the mitral stenosis or the mitral regurgitation will increase because of the increased blood flow through the heart. Now we have discussed the increase of afterload and the increase of the preload. Going through the same concept, if we remove all this again, and let's concentrate on certain conditions in which there is a decrease in the preload. Now, how can we decrease the preload? We can give a venodilator to the patient. We can give a nitrate, which will lead to the venodilation and the blood will not go into the heart. Or we can do any bedside maneuver. We can ask the patient to lie supine. This way they can increase the preload. So we can ask the patient to stand. When the patient stands, the blood starts pooling into the peripheral venules, and there will be less blood flow through the heart. So by asking the patient to stand or giving him a venodilator like a nitrate, we can decrease the preload through the heart. So what happens with the decreased preload? Whenever there is decreased preload, the heart becomes kind of shorter because the blood flow will start slowing down to the heart. So the obstruction, as in case of hypertrophic obstructive cardiomyopathy, as I told you, this will start getting more, and it will be difficult for the heart to get rid of the blood, and the obstruction will start increasing. So this will lead to an increase in the murmur of hypertrophic obstructive cardiomyopathy. Similarly, following the same concept, as these two murmurs mirror each other, the murmur of the mitral valve prolapse also increases. This means that the mid-systolic click will start shifting towards the left side or towards the S1, and the duration of the murmur will also increase. What happens with the murmur of the aortic stenosis? Let's look at it. When there is decreased preload, the transvalvular gradient will start going down. Going down means the left ventricle will have less blood and the pressure in the left ventricle will start decreasing. The aortic pressure will remain the same. So this transvalvular gradient going down will lead to the softening of the murmur of aortic stenosis. So the aortic stenosis murmur generally goes down, and generally the rest of the murmurs also go down. So the important thing here to remember in context of these bedside maneuvers is the hypertrophic obstructive cardiomyopathy murmur and the mitral valve prolapse murmur. They will go in the same direction with whatever maneuvers you are doing. Okay. The other thing to remember is, except from increasing the afterload, like the heart grip, the murmurs of the hypertrophic obstructive cardiomyopathy and the aortic stenosis will go down or go in the opposite direction. So these murmurs, these bedside maneuvers are able, with the help of these bedside maneuvers, we are able to differentiate what is going on here in terms of the cardiac pathology. For example, in some old patient, we might have some difficulty in recognizing aortic stenosis from a known case of hypertrophic cardiomyopathy, or a murmur of mitral valve prolapse may be difficult to differentiate from a murmur of, let's say, mitral stenosis or a mitral regurgitation murmur radiating towards the axilla. So with the help of these bedside maneuvers, we are going to differentiate the certain characteristics of the murmur, and they can give us a very good idea moving forward with what investigations we are going to do. So now let's get back to our slides and discuss these points again. Now, I told you what happens with the murmur of when we do a hand grip. This increases the afterload, and this is the dynamic process which can alter the afterload and lead to various alterations in the murmur. Similarly, transient arterial occlusion, with the help of a BP cuff on both arms, we can constrict the arterioles. This also leads to the increase in afterload. We can pharmacologically manipulate the preload and afterloads with the help of vasoconstrictors or vasodilators. These can alter these dynamics and can lead to an alteration of the murmur. Valsalva maneuver. What is a Valsalva? You know, Valsalva maneuver is when we close the epiglottis and try to expire and get the air out of our lungs. What does this do? This leads to an increased pressure in the transthoracic cavity, and this leads to a decreased venous return or a decreased preload. It is similar to, you can say, a patient standing, or someone you have given a vasodilator. So there will be decreased blood flow through the heart, a decreased preload, and it will alter the murmurs. As I just told you, that with the help of a decreased preload, the murmur of the hypertrophic cardiomyopathy will start increasing. It will increase in intensity. The murmur of the mitral valve prolapse will increase in intensity. The aortic stenosis murmur will go down, and the rest of the murmurs are also going down. Similarly, rapidly standing, making a patient rapidly stand, there is decreased preload, or squatting will increase the preload, and they will alter the dynamics as we just discussed on the whiteboard. And with the help of if we passively if we passively raise the patient leg, what happens is this can be done in an older patient who is unable to squat, and this is an alternative to squatting, you can say. By raising the leg passively, the blood flow to the heart will increase, and this will lead to an increase in the preload. Another thing is a post-premature beat. This is the point which we are going to discuss in the coming slide. So all these points are very well explained with the help of a whiteboard, which I just explained in the previous part. And just remember with the various maneuvers how they are going to alter the preload and the afterload, and you are going to make up with the help of a concept of the understanding of the pathology what are going to be the different dynamic changes occurring in the patient on the bedside. Here we just demonstrate a few auscultation points in regards to the respiration. Discussing our first point of the dynamic auscultation, the respiration. I told you that the murmurs of the right hand side increase with inspiration, and the murmurs of the left heart increase with expiration. So we generally auscultate the chest in this direction. We start from the right infraclavicular area, go to the left infraclavicular area, then to the second intercostal space. You have to make a figure of 2 here. So you can see there are 2 figures of 2, starting from here in the right side, then from here, here. This will cover all the lung areas, and you won't miss a thing occurring in the various lobes of the lung. And generally there are 10 auscultation points in the front and the 10 auscultation points in the back. You again make a figure of 2 here, starting from the left side this time. So these show the auscultation points, and while you are auscultating the patient, you can see for the chest if there is any chest pathology going on, or are there any alteration in the breath sound in some lobes of the heart, some lobes of the lung. Now, another important point to understand here is the splitting of the heart sounds with the help in relation to the respiration. As I just told you that during expiration, the right side of the heart receives greater blood flow because there is a decrease in the transthoracic pressure. There is an increase in the negative transthoracic pressure, you can say, to facilitate the understanding. So the lungs become a pooling organ, and the blood flow increases to the right hand side of the heart, through the right atrium to the right ventricle. Because of this, during inspiration, the second heart sound, which is because of the closure of the aortic valve and the pulmonic valve, is kind of split. In the expiration part, you can generally say that we hear a single sound, the S2. But during inspiration, because of the increased blood flow through the right-hand side of the heart, there is delayed closure of the pulmonic valve. And this leads to a slight gap between the 2 components, the A2 and the P2. And if we hear the second heart sound on inspiration, we can appreciate this gap in a normal person. This is the normal physiological splitting. Now, let's discuss a few conditions when there is alteration of this pathology. What are the various conditions where this physiological split, which is generally narrow, increases? As you can compare the two here, the inspiration during the expiration, the split is kind of the same, but during inspiration, there is a widening of the split, or the P2 becomes further delayed for closure. This wide physiological split occurs in some pathology in which there is further decrease in the blood flow to the pulmonic valve, or further delayed closure of the pulmonic valve. The 2 important conditions here to remember are the right bundle branch block and the pulmonic stenosis. These are the 2 conditions that lead to a wide physiological splitting during the inspiration. In some patients, the splitting can be reversed. You can see here the A2 closes later on while the P2 closes before the A2. And during expiration, when the P2 is delayed, you can kind of hear a similar sound. The S2 becomes a single sound. This becomes a reverse process, so we label it as reverse splitting. What are the conditions when this can happen? If in some condition there is delayed closure of the aortic valve, what can be those conditions? For example, if a patient has aortic stenosis or there is a left bundle branch block, this will lead to a delayed closure of the aortic valve as compared to the pulmonic valve. And the timing of the splitting is reversed, that during inspiration we have a single heart sound, the S2, and during expiration there is a widening of the heart sound. Similarly, there is a condition, important one to remember, when there is a narrow physiological split, that the A2 is at its place, but the P2, instead of becoming split here, moves towards the S2. So this can be a condition in which there is an increase in the P2. What can be a condition which can lead to an increase in the pulmonic sound? If you take heed, you can make it out very easily that any condition that increases the pulmonary arterial pressure or any condition that leads to pulmonary hypertension, for example, the left heart failure or COPD, chronic COPD in a patient, or any pathology in the lungs of the patient, for example, a pulmonary embolus, that can lead to increase in the pulmonary arterial pressure or pulmonary hypertension. The pulmonary hypertension is one condition because of any reason that leads to a narrow physiological splitting, or the P2 will move closer to the A2. You can see here that even during expiration and similarly during inspiration, there is a narrow gap between the two components, and you can practically hear the S2 as a single sound throughout the expiration and inspiration. So these movements of the first and the second heart sound in relation to the respiration are important to understand and remember as regards to your exam and in your clinical practice as well. Now, if we have an older patient and there is some rhythm abnormality going on in an older patient, and if we do an ECG of the patient and there you see compared to a normal ECG in a person, some patients have premature ventricular contraction, which we label as PVCs, because of any abnormal rhythm. These premature ventricular contractions are the ones which are occurring before their regular time, and they have slightly increased in amplitude. For example, you can see the QRS amplitude and the QRS thickness is more here as compared to the normal QRS. So what is this concept important in regards to the murmurs? The important thing here to understand are to differentiate between two murmurs. For example, if we have an older patient and we auscultate the chest of that patient and we are unable to differentiate what the murmur is going on, because there is some rhythmic abnormality. For example, the patient is also having PVCs or premature ventricular contractions. What happens with the premature ventricular contraction is, instead of normally contracting in synchrony, the ventricle contracts just prematurely before a beat. So this leads to an increased pulling of blood into the ventricle or the increased expansion of the ventricle. And in this patient, if we suspect that whether the patient has aortic stenosis or whether the patient has mitral regurgitation, I told you that the murmur of the mitral regurgitation generally radiates to the axilla, but if there is a posterior leaflet of the mitral valve involved, then the murmur can also lead to the base of the heart, towards the aortic point, the right second intercostal space. So if we are appreciating the chest of the patient, we hear a murmur in the right second intercostal space, and we are unable to, because both are systolic murmurs, and we are unable to appreciate or differentiate that whether this murmur in this patient is of aortic stenosis or whether this is a mitral regurgitation murmur radiating to the base of the heart or the second intercostal space. And so the important clinical point here to remember is, after a PVC or a premature ventricular contraction, there will be an increased blood in the right side of the left ventricle, and when the next contraction will begin, it will be large contraction, and because of the stalling forces, the increased blood in the left ventricle will allow the heart to contract more forcefully, and this will lead to an increased transvalvular pressure across the aortic valve. So the murmur of the aortic stenosis just after a PVC or a premature ventricular beat will be louder as compared to the murmur of mitral regurgitation. The increased blood in the left ventricle will not affect the murmur of the mitral regurgitation a lot. So post the PVC, if we hear a loud murmur in a patient, that murmur at the right second intercostal space, we can safely say that that is a murmur of aortic stenosis. Or if post PVC the murmur intensity remains the same, then we can see that this might be a murmur of mitral regurgitation as compared to the aortic stenosis. So these two murmurs are the important in regards to this context of the post PVC. Now, after discussing the murmurs in the great detail and then looking at the various dynamic auscultation procedures or the bedside maneuvers we can do to have further information regarding the patient's pathology, the definitive diagnosis is made with the help of certain diagnostic tests. And the number one diagnostic test to do is an echocardiograph. Echocardiography with color flow and spectral Doppler, or the transthoracic echocardiography, where we place the handle of the machine on the chest of the patient, and we, with the help of a spectral Doppler and the color flow, we can appreciate the various chambers of the heart. Echocardiography, as I'm going to explain in the coming slides, is a gold standard technique or the gold standard test to definitively diagnose the pathologies of the valves, the valvular pathologies. If we suspect something is going on with the shape of the heart or the cardiac chamber thickness, or if we suspect there are some structural changes going on in the heart, or there is some abnormal movement during the various cardiac cycles, with the help of this color flow and spectral Doppler, we have a very good indication, we have a very good reading of the various chambers of the heart, and whether there is some septal defect, some mixing of the heart. The red side, part here of the Doppler generally indicates oxygenated blood flow, and the blue generally indicates the deoxygenated blood flow. So echocardiography is the gold standard technique to diagnose the mitral valve or any valvular pathology, or any where we want to discuss in greater detail the chambers of the heart. And this leads to this confirmation of our clinical findings and leads to definitive diagnosis in the patient, so that we can confidently move ahead with the management of the patient. What are the various indications of the echocardiography? These are important to understand and remember. Let's start off with, as we told you in the systolic murmurs, any early, late, or a hollow systolic murmur is an indication for echocardiography. Similarly, we have excluded the mid-systolic murmurs in the first part because the mid-systolic murmurs are graded. Grade 3 or a louder mid-systolic murmur, any murmur which is very easily appreciable with the help of a stethoscope, we do an echocardiograph. What can be a mid-systolic grade 3 murmur? Murmur of aortic stenosis, most likely a crescendo decrescendo murmur or hypertrophic obstructive cardiomyopathy murmur. Similarly, if there is a grade 1 or 2 mid-systolic murmur and there are no symptoms of the cardiovascular disease, we don't do echocardiography in that case. But if we have a grade 1 or grade 2 mid-systolic murmur, for example, a patient with aortic valve sclerosis, and there are some symptoms of the cardiovascular disease, for example, the patient presents with angina or syncope or dyspnea, and there is a slight murmur, that gives us an indication to do the echocardiogram to look at the heart and what is going on with the aortic valve. Similarly, all kinds of diastolic murmurs, the early diastolic murmurs, the mid to late diastolic murmurs, we will do an echocardiogram to definitively diagnose what is going on with the patient. Continuous murmurs, for example, patent ductus arteriosus, is an indication for echocardiography. And to verify the normal cardiac structure and function, to look at the various measurements of the cardiac chambers, we also do an echocardiography. So generally, in general terms, just remember that whenever there is any pathology of the valve or the structural chamber, echocardiography is a gold standard test, and it gives us a very good indication of the ejection fraction, of the various movements of the heart during systole and diastole, whether there is any abdominal movement or there are any septal defects or any abnormality in the cardiac structure and function. This is the first step we do, and this generally gives us a very good diagnosis of how to proceed further with our management. Now, apart from this normal transthoracic echocardiogram, which we have just discussed, there are certain other variations. For example, we have a patient who is very obese and there is a lot of fat between his chest wall and the heart. So in that case, patient, the transthoracic echocardiogram might not be a very good modality, testing modality, because there will be a lot of fat and we won't be able to appreciate the chambers fully. So in those patients, a very good alternative is a transesophageal echocardiography, the TEE, in which we go through the esophagus and then with the help of this device, we are going to appreciate the heart and the various chambers. Most importantly, this is very important to discuss or diagnose the pathologies of the left atrium or the mitral valve. You know that the left atrium is the most posteriorly placed chamber of the heart. Any dilatation of the left atrium will lead to a pressure on the esophagus, and certain patients with atrial fibrillation or certain patients with long-standing mitral stenosis in which there is atrial dilatation can present even with dysphagia of this. There is narrowing of the esophagus in this part and the food can get stuck here. So in patients in which the transthoracic echocardiogram is not very helpful, transesophageal echocardiography is a very good alternative, or in patients in which we want to appreciate the mitral valve or the left side of the heart, the left atrium specifically, transesophageal echocardiography is a go-to technique. Similarly, we can do an MRI of the heart, which is called electrocardiographically gated cardiac magnetic resonance imaging. The MRI is a very good modality. It gives us a very good appreciation quantitatively as well as to various thickness of the various chambers of the heart, whether there is some asymmetry in the septum in patients of hypertrophic cardiomyopathy. It gives us a good indication of the blood flow or the valves, the structure of the generalized heart. So CMR imaging is also a very good technique as other alternative. Similarly, if we have a patient presenting to us with a valvular pathology and we suspect that there is some problem going on with the coronary arteries in this patient, and the patient is having signs and symptoms of the ischemic heart disease, invasive coronary angiography, in which we insert a dye and visualize the coronaries, is a very good technique to go through. In certain patients, for example, an older patient which we suspect an MI going on or some other pathology. And this can also be a very good treatment modality, that when we are visualizing the coronaries, if you can find a clot there or a block in the blood flow, we can remove it with the help of a balloon catheter, or we can place a stent there to bypass that thing. So this invasive coronary angiography can also be done in patients suspected of having any ischemic heart symptoms, in a patient presenting concurrently with a valvular disease or any other pathology. Similarly, we can do a CT angiography. CT angiography is an alternative to an invasive procedure, and this is generally done in a patient who presents with a valvular pathology, but there is a low pretest probability of the patient having a ischemic heart disease. For example, if we are suspecting that the patient is having a heart disease, ischemic heart disease, and the patient is an older patient and he's been having a lot of dyspnea on rest. In those patients, when there is increased or high pretest probability of having an ischemic heart disease, we do the invasive procedure so that we can relieve the obstruction if there is any obstruction present. But if in a younger patient, for example, a patient after a rheumatic fever, a young patient has mitral valve disease, and there is a decreased pretest probability of this young patient having any ischemic heart disease concurrently, we do a CT angiography, which is a non-invasive procedure as compared to this invasive technique, to rule out or to look at the coronaries and the various parts of the circulation of the heart. So these are the basic cardiac testing which generally employed to look at the heart. The gold standard is a transthoracic echocardiogram, and these are the various alternatives or certain other techniques which we can do. Now, in the last part of the lecture, we are just going to summarize what we have learned, and with the help of a flowchart, we are going to go through an integrated approach as to how, if we have a patient with a cardiac murmur, how we are going to approach the patient clinically, and then afterwards, what are the different tests and what are the indications of the various tests we do in such patients. For example, so we have a patient with a cardiac murmur. First thing is to categorize the murmur with the help of a examination of the stethoscope, whether the murmur is systolic, diastolic, or a continuous murmur. If we have a patient with a systolic murmur, we grade the murmur. Number one is to differentiate the various parts of the systole, whether the murmur is an early systole or late systole or a holosystolic murmur, or whether in the mid systole the murmur is grade 3 or more, for example, aortic stenosis murmur. If we have these indications, this is generalized indication for a transthoracic echocardiogram, as we discussed in the indications of the echocardiogram. On the other hand, if we have a mid-systolic grade 2 or less murmur, then we have to look at the bigger picture. If there is a grade 2 or less mid-systolic murmur and the patient is asymptomatic and no associated finding, for example, this is an accidental finding during a general physical examination for a job test or anything in a young patient, in this case, and the patient is asymptomatic, no associated finding, we don't do anything. We don't go for the transthoracic echocardiogram. But if the mid-systolic murmur presents with the other signs of the cardiac disease, the patient has dyspnea or angina or syncope, so that gives us a very good indication, and we do a transthoracic echocardiogram in such patients. So any systolic murmur, apart from the mid-systolic grade 2 or less, we do a echocardiogram. In a grade 2 or less murmur with the symptoms of the cardiac disease, we do a transthoracic echocardiogram. Let's go to the other side. If we find a diastolic murmur, for example, a murmur of mitral stenosis in a patient, we do a transthoracic echocardiogram. All the diastolic murmurs are the indications of a transthoracic echocardiogram. The other alternatives are the transesophageal echocardiogram, the cardiac MRI, or catheterization if there are symptoms of the ischemic heart disease. Now let's look at the continuous murmur, for example, the murmur of patent ductus arteriosus, or if we have a murmur of patent ductus arteriosus, that is an indication of a transthoracic echocardiogram. But if the other signs of the patent ductus arteriosus are not present in the patient, for example, there is no peripheral cyanosis or no decreased saturation of the right side of the heart, then that we can safely say that that can be a venous hum, or that can be a memory souffle, or that can be because of some AV malformation naturally occurring place. In those conditions, we generally don't go to look at the heart, because that will be futile to look at the transthoracic echocardiogram. But in a patient suspected of PDA or patent ductus arteriosus, we do an echocardiography to look at the extent of the patency and what are the various things going on in the heart. Similarly, these two, if a mid-systolic murmur is grade 2 or less and the patient has no symptoms, or if we have a naturally occurring venous hum or a AV malformation which is not very pathological, no further workup is needed at this point. And then we can follow up the patient after a certain period of time to look at that whether his grade of the murmur has increased to the grade 3, or whether the patient has developed any signs and symptoms of cardiac disease, which can eventually then lead to this investigation of the thoracic echocardiogram. So just remember that all the various indications of the transthoracic echocardiogram, these are going to be very helpful for you in answering your test questions and also in your practical life during your rotations in cardiology. And transthoracic echocardiogram is the gold standard technique to diagnose the conditions of the valves and the various chambers, any structural heart disease going on. So this concludes our two-part lecture on the heart murmurs. In the first part, we discussed the systolic murmurs, the various characteristics of the murmur in detail, while in the second part of the lecture, we discussed the diastolic murmurs initially. We went to the various bedside maneuvers, which can help us in giving us very important clues regarding the patient's disease on the bedside before we move on to the expensive and the time-consuming modalities, the test modalities. Then we discuss the various diagnostic modalities, the echocardiogram, the indications of the echocardiogram, and in the last slide we had discussed an integrated approach as to how we are going to proceed with the different types of murmurs in relation to their intensity or their location. I hope you have learned something new through this lecture, and I'll see you in another lecture. Thank you for watching sqadia.com.